I think there's probably someone in the room who's actually reading this a little bit different, and they would probably say, who needs it? But I'd like to show you today that there is a role for EUS. I want to discuss how we make that diagnosis and then the categories of people who might benefit the most from having that procedure performed. The categories of need really come into three different ones. One is actually confirming the diagnosis. This would be in the person with unexplained abdominal pain. We do need it to expand our differential diagnosis because we can have tumors or cystic neoplasms that will confuse us, and we may mismanage this patient. In particular, no one wants to drain that pseudocyst that's actually a cystic neoplasm. Today we'll also talk about FNA, and we'll look at some imaging changes that we're trying to make to improve our accuracy. We do have a third arm here, which is EUS therapy, celiac plexus blocks, pseudocyst management, and duct access. You can thank Rob that I'm going to eliminate this a portion of this from my talk, so it'll lead to an earlier break. When we do EUS, you get more for your money than you're used to because you get an evaluation of the condition of the gallbladder, the common bile duct, the pancreatic parenchyma, and the duct. We're also looking at changes which may tell us about cystic neoplasms like dilation greater than 5 millimeters, whether cysts communicate, and we do fairly well at the diagnosis of divisum. Any lesions, of course, that we find would undergo fine needle aspiration. The advantages of EUS are that it is high frequency and high resolution. There's no overlying bowel gas. The patients usually are not moving because they're sedated, and the safety is equivalent to that of an upper endoscopy. The disadvantages are expense, unless you see the current CPT codes, and then that's less of a problem beginning in 2014. The availability is variable across the nation. We achieve structural information only. Obtaining training can be difficult because so few centers have the volume to actually do it well, and it's in particular difficult for those who are already in private practice. I think the one thing we should be very aware of in EUS is the potential for overdiagnosis, and we're going to rediscuss that when we come back to evaluation of unexplained abdominal pain. When we're looking at EUS as a diagnostic test for chronic pancreatitis, we have to be able to know normal from abnormal. We have arguments over what is the gold standard, so we have to compare ourselves to pancreatography, function testing, histology, and of course natural history. What happens to those patients over time that EUS says is abnormal and the other tests do not. The way in which we got our criteria for EUS were quite simple. We just stole them. We stole them from Dr. Cotton's work on the Cambridge classification, looking at ductal abnormalities to give us categories for duct changes. And within his unit also was Dr. Lees, who was doing transabdominal ultrasound and found that there were changes in these patients with chronic pancreatitis, including not only the ductal changes of dilation, echogenic walls, irregular contour, side branch ectasia, and calcifications, but parenchymal changes like hyperechoic foci, cyst, lobular outer contour, echogenic strands, and inhomogeneity. So we took all of those and made them into our own classification system. There have been lots of theories about what the histologic correlates are, including things that may relate to periductal fibrosis, obstruction, stones, fibrosis, duct leaks, acute inflammation, and fibrosis. But we know that if we do an EUS and immediately resect that area of the pancreas, that there's not a one-on-one correlate with these, and that in part is related to the patchiness of the chronic pancreatitis in the specimens themselves. If we try to choose the criteria that we need for EUS to make the diagnosis of chronic pancreatitis, we can be overly sensitive the lower the number of criteria that we use. But if we look at the operating curves, as we increase our number of features, our specificity increases, and we have now chosen to go to a level of 5 or more to make that diagnosis. If I am looking at the picture to your left, that is what a normal pancreas looks like. It's a salt and pepper pattern. It has a normal looking duct. It's not dilated. It's not irregular. And if I look at the comparative ones on the right, even from the back of the room, you can see that those are not normal. You can see the lobularity. You can see this irregular duct with the side branches that are dilated. The problem across the nation is that people are different in their calls on the minor criteria. And this has led to a lot of problems with potential overdiagnosis using endoscopic ultrasound. The agreement between the observers themselves and within their own reads was studied by Dr. Mike Wallace. In this study on intra-observer agreement for EUS and chronic pancreatitis, he had 45 standard videotapes that were rated by 11 expert endosonographers, and I put expert in quotations because Rob and I were in that group and we may not be counted that way. Each examination was rated for the presence or absence of individual features, and then the patients were given a global diagnosis, yes, no, is this chronic pancreatitis? And what we see is that we do agree on dilations. We don't agree as much as you might think on lobularity and on actually on what might be called stones. So although this is reasonable in comparison to other endoscopic inter-observer studies like is this a visible vessel in GI bleeding, it still has some problems. So a group of individuals met in Rosemont to try to basically redo the Cambridge type of classification, make this a little bit more scientific, and see if we could make it a little bit more stringent for the diagnosis and universal across the U.S. They developed major A criteria, including main pancreatic duct calculi or hyperechoic foci with shadowing, basically stones, greater than 2 millimeters in length and width in the parenchyma. Major B includes lobularity with honeycombing, and they define the criteria for these greater than 5 millimeter with more than 3 lobules. The other criteria that we've mentioned before are considered minor. If we look at the classification systems for what we've had in the past for Rosemont, we can see that in the more normal type or conventional, we have less than 2 as being normal, 3 to 4 as being indeterminate or intermediate, and high probability is 5 to 9, or the presence of calcifications or stones. For Rosemont, the normal is, again, less than 3, which is 2 or less. The suggestive is major A plus 3, less than 3 minor, major B, 2, as you see, and the 5 minor categories. The compatible with goes into the more obvious types of criteria, with the 2 major A, 1 major A, and greater than 3 minor features, or the major A plus a major B. So did that really help us in doing this? We've tried to look at that agreement at our own institution and others, comparing Rosemont to conventional criteria, and the answer for most places is it really didn't help us that much. So we still have a problem with our sensitivity being very high and the potential for overcall being high. Again, back to this accuracy characterization of EUS for chronic pancreatitis, we have to look through these different categories. The normal appearance of the pancreas is a salt and pepper pancreas with a non-dilated duct. We don't normally have cysts or calcifications. EUS and normals were done in different centers across the U.S., and basically they found the type of pattern that you see in transabdominal ultrasound, which is that there is a fine granular or reticular pattern. It's fairly homogeneous across. The ducts aren't dilated. We use 3, 2, and 1. For example, versus ERCP. We don't tend to have cysts in the normal pancreas, and we don't usually have stones. How does EUS compare to these other tests, and is your diagnosis actually improved? Is EUS easier? Is it safer? Is it better than ERCP, MRCP, or function testing? Can EUS diagnose chronic pancreatitis when these other tests are normal? And overall, the question always is, what is the gold standard? If we look at our comparative studies for EUS versus ERCP, ultimately the EUS diagnosis is the sum of the abnormal features. And for a slide to be made of the different centers who have looked at this, it would be too busy to analyze. But basically, the data suggests that chronic pancreatitis is confirmed if you have usually greater than 5 criteria, but greater than 3 corresponds with a Cambridge grade 3. The finding of less than 3 EUS criteria has a negative predictive value in those studies of better than 85%. Meta-analysis of EUS and ERCP have shown us that, of course, sometimes one is normal and the other one is not, or vice versa, but there is an agreement in about 80% of the cases. If we look at EUS versus function testing, I'm going to just abbreviate that because Dr. Stevens is going to talk about that in just a minute. But for many of the studies, the characteristics come out the same. There will be times when one test is normal and the other one is not, and then again, we have to argue about which is the gold standard. In terms of combined test, the overall agreement is about the same as ERCP, which is around 88%. There will be times when one of these is out of sync. In looking at EUS versus histology, there are 4 studies of any size. The largest one to date being ours at the Medical University of South Carolina, in which we had 71 patients who had EUS and then had comparative surgical histopathology. In non-calcific chronic pancreatitis, 5 criteria were needed to have the highest specificity, and that was 100%. Dr. Marty Freeman shared with me an abstract that he has that suggests that in his patients undergoing transplant that the ERCP may not function at that level, and I'll be interested to see that at DDW hopefully. Looking at MRI and chronic pancreatitis, we saw a lot of that information yesterday, but not as an insult to our radiology colleagues, but we tend to see a lot of pretty slides, but we don't see a lot of comparative studies. We definitely don't often see randomized controlled trials looking at these types of things. Most of the studies in MRI have been done comparing MRCP with pancreatograms, with ductal abnormalities at the time of secretin MRCP versus ERCP, and or pulmonary function testing. There are very few studies that actually, if you read through them, compare EUS and MRI. Again, Dr. Freeman had another abstract. He was tearing apart all of my arguments for today by showing me one that he has that does have a comparison in those and doesn't show EUS faring very well. The problem with MRCP will be that some institutions, perhaps like his, perhaps like ours, do very well in MRI. But if you don't have a defined scoring system for this and you have very variable protocols across the nation, then you are not going to have reproducible, reliable data for which one of these is correct. If we look at natural history in terms of do patients with minimal change of EUS criteria progress to overt disease, our studies at our university have answered that in a positive, saying yes, they do seem to have within 2 years a change to minor duct findings, persistent pain, and become a Cambridge Class 3. But there is disparity in the data, different universities reporting different types of data. The problem with all of these studies has been that they are performed by an individual who is unblinded to the data, and this is a significant source of bias in these types of studies. In summary for EUS, in terms of making a diagnosis of chronic pancreatitis, there is a strong correlation with ERCP and function testing, depending on the number of criteria that you use. There, in about 15 to 18% of these patients, there will be isolated abnormal EUS findings, but the correlates with histology suggest that this is real disease. The specificity and positive predictive value depend on the number of features, with 5 and more being more definitive, but I would suggest to you that equivocal EUS needs further confirmation. You need to really think about whether you want to label that patient with chronic pancreatitis when the findings are equivocal. This leads to our discussion of using EUS in this patient population of unexplained abdominal pain. And this is our modern day version of Pandora's box. And we opened it here because we did the original work looking at the use of this in unexplained abdominal pain, particularly dyspepsia. And what we discovered was that we could decrease the cost for evaluation of abdominal pain, upper abdominal pain, using EUS versus a combination of upper endoscopy and body imaging. At that time, we were using CT scan. What people don't pay attention to is that this was a highly select group. This is not your person that you're think probably has functional bowel pain, but you're going to send them for an EUS just to see. If you do that, you fall under the old axiom of a poorly indicated test is always positive. So you're going to come out with indeterminate criteria often in those patients. The other thing you need to remember if you're choosing this for your patient population is that 49% of patients with nonspecific dyspepsia who have a history of drinking alcohol, 2 or more drinks per day, have 5 or more features of chronic pancreatitis by EUS criteria. So you're going to come out, you have to be selective in the patients that you're, in whom you're using this test. EUS is an overly sensitive test. The differential diagnosis, I think, is where EUS plays a very major role still. We still are capable of defining small tumors more readily than other imaging studies, MRCP, even CT scan, when they are small. And the literature from recurrent acute pancreatitis tells us that neuroendocrine tumors need to be considered in that differential diagnosis. And of course, the differential is recurrent acute versus chronic pancreatitis. So it comes into play there very much so. Let me give you an example that we saw 2 weeks ago. This was a 65-year-old male who presents with weight loss and abdominal pain. A CT scan shows an atrophic pancreas with scattered calcifications and a dilated main pancreatic duct. But these calcifications were tiny. They were actually on the outer contour of the pancreas in the body and tail. There were very few of them, and the PD was markedly dilated without evidence of a focal stricture. So they were concerned that there was something else going on in this patient. Was it a patient who just happened to have an older presentation of chronic pancreatitis, but the patient had no risk factors for it, and he was referred for EUS to confirm the diagnosis. In this slide, which is a little bit dark here for you, this is the muscularis propria of the duodenum. This is almost not recognizable to you because it's such a dilated main pancreatic duct. And what is very nicely demonstrated is that this runs completely through the wall, through the ampulla. So in this person, that does not make sense for that to be chronic pancreatitis and to have that duct dilated there. And what we are seeing is actually that this person has a classic fisheye appearance to their papilla, and we are seeing the duct come out right at the orifice of the papilla and extruding mucus, and this was a main duct variant of IPMN. Okay. So you need it for these cystic lesions, not only IPMN, but also in pseudocyst, which may have up to 5% actually as cystic neoplasms, and we need it in focal lesions. We know that cancer occurs more commonly in chronic pancreatitis, but it can be very difficult to make the distinction between that pseudotumor and a real one. In fact, our sensitivity in EUS is 74% in calcific chronic pancreatitis. Sometimes you just can't see beyond that concrete block in the head. You just don't know. You can increase this accuracy to 84% if you do repeated sampling, if you do 8 to 10 fine needle aspirations at the time of your initial procedure, or importantly, if it doesn't show it at that time, you're not sure, you can bring them back in 4 to 6 weeks and pick up another 10% accuracy by repeating the biopsies. So you can buy some time with this and have an improved yield if you bring them back. We've tried other things. We tried adding molecular analysis to this. We've done different types of microsatellite instability, KRAS abnormalities, and none of them have pushed us to the accuracy rates that we see with regular tumors, which is above 95%. We also have tried changing our needles. We have a very broad array of needles that we can choose from now. When I started, there was one needle, and it usually broke at some point during the procedure to where you had to pull it out with needle nose forceps. So we've come a long way in the use of our needles. For many of these, they are actually core needles, like this one from the Cook company, and they allow us to get more toward histopathology, so it can be more helpful. And I think this will play a role too as we become more focused on the responsiveness of patients' tumor to different types of chemotherapeutic agents, and we become more designer as they have, for example, in lung cancer. The autoimmune pancreatitis has been discussed several times here, and the difficulty in making the diagnosis it has been very well stated. We had a TrueCut biopsy needle that did, when it worked beautifully, and you had a large sample that would truly do histopathology. The problem was that it really didn't work all that well in everyone's hands, and we would make jokes about, you know, is the moon full or is our tongue positioned right when we're firing the needle, because that's how unpredictable the needle was. And that one has pretty much gone by the wayside. But the newer needles do not give you the amount of tissue that we saw with the true cut biopsy needle. So the data became more variable on whether or not you could actually make a tissue diagnosis of autoimmune pancreatitis. And I would say to you that it's primarily useful to have FNA for exclusion of malignancy. So because we're still trying to define where the cancer is in these inflammatory masses, I'm working to try to figure out the big neon arrow that points to where to FNA. And a lot of different techniques have been tried. One is elastography, in which we use evaluation of the tissue strain to try to tell us if something has more or less vascularity. In studies that have been reporting their sensitivity and specificity, they are usually somewhere around 90 and 88%, with accuracies around 90%. So we're still not to that 95 and above that we are otherwise. The problem with elastography is it does not work well with lesions that are large, greater than 3.5 centimeters, or if they are at a distance from the transducer. So helpful information, but not there yet. We've also used contrast-enhanced endoscopic ultrasound. Here's a study from last year using low index contrast enhanced ultrasound to try to detect these differences in vascularity of the cancers versus chronic pancreatitis. And again, our sensitivity is reasonable, but our specificity is not, and it needs more work. I'm trying to do some work using actually nanoparticles in contrast to target these tumors within the inflammatory mass to see if we can point our finger to where the biopsy needs to be done. Celiac plexus block will be discussed a little bit later here today. For me, in terms of what patients need this, I don't think this is the end-all and be-all answer to these patients. I see it as an adjunct to trying to decrease their narcotic use. We sometimes use it in these patients that are difficult to get out of the hospital. You need a crowbar to get them out the door, and EUS plexus block can sometimes be that crowbar. You've heard a lot about pseudocyst drainage. I'm not going to go back through all of that or the main pancreatic duct changes, but there is something that we need to remember, that EUS may identify tumors in 5% of the cases. In summary, we've talked about this. EUS is highly accurate in either end of the spectrum for criteria. There is a high negative predictive value if EUS is negative. FNA can be extremely helpful, and think of EUS in those patients who need therapy. Thank you.